We are about to begin an essential session on transition to adult care in context of diabetes and other endocrinal diseases. This topic is crucial for ensuring continued and effective care as these patients move from pediatric to adult healthcare systems. It is my great honor to invite our esteemed chairpersons who has significant expertise in managing these transitions in endocrine cases. We have with us none other than Professor Anju Seth. She is Director Professor and Head, Department of Pediatrics, in charge Division of Pediatric Endocrinology, Lady Hardinge Medical College. She has been the former Secretary and President ISPE and former APES Council member. Her areas of interest are vitamin D deficiency and related disorders, childhood diabetes, thalassemia. She has about 200 papers in index journals with total citations of 2,960. And Sir Professor Sanjay Kumar Bhadada, he is professor and head Department of Endocrinology, PGIML Chandigarh. He has interest in diabetes in young and metabolic bone disorders and has received many prestigious awards in his lifetime. I welcome both of you. Now I invite both of you to please take lead of the session. Thank you.
This is the last session of the conference, and I do sincerely hope the hall fills up more than what it is right now. So this session is a little different from the previous sessions we've had, and we are talking about what is currently increasingly been felt as a felt need. And most appropriately, it is being chaired by a pediatric endocrinologist and an adult endocrinologist. So for the first session, I invite Professor Raul Leon. Professor Leon is a general physician, La Salle University at the Mexico City. Professor Leon, kindly give your talk. He's going to speak to us on transition of adolescents with type 1 diabetes. Sir, please go on.
Thank you, Dr. Seth. First, I want to thank you for the invitation to this extraordinary Congress, the Young Congress, to this amazing country. So I will talk about transition and type 1 diabetes and our experience in the National Institute for Pediatrics in Mexico City. There is a difference between transition, which is a process which needs be structured, and the transfer, that is, you are in and now you're out of my service. Transition is an active and multidisciplinary process that covers different medical, psychosocial, and educational needs in which the adolescent or young adult prepares for self-care, requires the growing and developing adolescent to assume diabetes self-care responsibilities, and should begin at 12 or 13 years of age, be gradual and be progressive. So the goals is that the glucose self-monitoring, insulin administration, schedule appointments, and their goals ensure proper procurement of medication and supplies are displaced from the parents to the child, considering that we are looking with an adolescent. Adolescence is a very difficult step in the life of everybody. And the poor management of the transition gives a less likely to attend regularity, higher likelihood of going on the emergency rooms and hospitalizations, negative repercussion on health, conditioning the evolution of the disease in adults, and significantly greater proportion of those without organized transition were lost to the follow-up. But transition needs always to involve the family, and we need to consider the culture, the educational level, the religion, the economy of the family nucleus, the family story and experience with diabetes, the metabolic control achieved, interest in self-care, the sense of self-efficacy, readiness for transition, and somatic and emotional maturity of the patients. which is different in boys and in girls. A girl of 17 years is almost a mature woman. A boy of 17 years is not a mature man. So in Mexico, in the institute I work, the average educational level of the parents is 4 or 5 grades. It's very low. The social levels are poverty and extreme poverty. The job performance, both parents work in 76% of the cases in the families. And is the grandmother, usually the mother, the maternal grandmother, who goes with the patient during the consultation. But the grandmother does not live with the family in half of the cases. So he is not committed with metabolic control of the patients. In the house, at home, mothers in 98% of the cases are responsible for metabolic control, and attendance at the scheduled consultation is low, between 60 to 85%. And online teaching attendance is very low, 43%. There are three main approaches to developing transition programs. The clinics dedicated solely to emerging young adults are better than the clinical focus on transition planning, which is better than clinics that incorporate care coordinations. At the National Institute of Pediatrics in Mexico, we are only 3 pediatric endocrinologists and 1 nutritionist, and we do everything. Occasionally, psychologists or psychiatrists intervene, and we have no diabetes educator because it is not considered as formal work in the government hospital. We design an education, training, emotional support for the patients according all the topics that are needed to be teaching to the patients. And we start a monthly online seminars established to analyze each of these aspects. Considering the recommendation of the ADAPEST, Endocrine Society, and ISPAT, reeducate the patient to a program that covers general aspects of type 1 diabetes is covered. Report the patient's evolution up to that point is completely and well-defined protocol between the pediatrics and adult diabetes teams. We avoid treatment differences by maintaining the regimen and objectives, but we have a coordinator, nurse, or social workers to contact patient by telephone up to 1 year later, evaluating patient satisfaction, the degree of metabolic control before and after the transition, and the regularity with which they attend visits. But we don't get all the patients in these steps. And we don't have 100% of alternatives or program recommended that during the first 3 to 6 month visit. We follow the international intentional defined patient-centered system. We begin at the beginning of the diabetes, and then around 14 to 16 years, the transition readiness assessment developed an individualized transition plan, which is the first phase. The patient must be involved in the management of their disease. Then between 16 and 18, in some cases until 21, but usually until 18, we develop ensure prepared screening and prepare transition communication summary for the patient and providers. This is the transition phase, and the patient must be treated by adult specialists. And between 18 and ahead, We don't delay according to the cognitive difference. We cannot transfer to adult care and integration into adult practice. And then we confirm transfer completion and elicit feedback, which is the evaluation phase. There are a lot of questionnaires that have been developed to assess transition rhythm. We follow the Transition Rhythm Assessment Questionnaire 5.0, the track, which is a 20 items validated measures. And we know that transition process is optimized with inclusion of coordination and inclusion of diabetes education and mental health clinician to develop individualized transition planning and assess treatment can be valuable. But we have very problems to get diabetes educators. There is a configured readiness score reported by patient versus caregivers. We know now that one point is what the medical team think that the patient needs, and the other is what the patient think. Because topics that are many important for us, the patient said that is not priorities, or is not important, or they don't want to know about it. So we need to dialogue with the patient about each one of the items. We develop a stage of educational program at the beginning of the disease, talking what is diabetes, type 1, why insulin is used, what is important, the capillary interstitial glucose training, identifying and managing hypoglycemia, cetosis, and ketoacidosis, sick days, meals plan and carbohydrate calculation, basal dose and boluses, exercise, and infusion pumps. Then, in an intermediate stage, we talk about self-identification and self-management of ketosis, ketoacidosis, and hypoglycemia. 6 days again, management during the holidays and vacation, how to adjust basal insulin doses and boluses, alcohol intake, sweets, smoking, drug addiction, contraception, high performance exercise, and chronic complication, and against infusion pumps. In Mexico, infusion pumps are not covered by the government health. And in the advanced transition, the importance of self-care is how to interpret capillary and interstitial glucose, sensors, infusion pumps, basal insulin and boluses, 6 days, holiday vacation trips, chronic complication, social alcoholism, addiction, genetics and inheritance, contraception, management during pregnancy, and where to go in adult life, if it's a social security system or a health insurance. So we send the patient to a third-level care hospital in Mexico City or in federal entities according where they live. And usually they are attended by adult endocrinologists, specialist staff of Taiwan diabetes too. But according to level of education, most patients didn't go to high school or university, and they work in a technical and not specialist jobs at 18 years and ahead, or they marry. And in this case, most of the patients going to a first or second level care hospital anywhere where they are not found adult endocrinologists, but general physician, internist, and staff is not specialized. So it's very different what happened with the patient if they continue with the family or they go to work or did not study or moves to another federal entity. We need to consider that adolescence is characterized by physiological change, psychological change, social change, tobacco and or vaping, alcohol, drugs, rejection of adult values, and leave the home. And besides the typical development of an adolescent, the patient with diabetes has another necessities, balancing care with school, work, and social interests, greater independence and need for adult support related to diabetes care, body imaging concern related to wearing diabetes device, concern regarding peer awareness and comments about type 1 diabetes, understanding exercise and diabetes needs, the diabetes self-care, which often loses priority to compete with demands related to social, emotional, educational, and occupational interests. There is a risk of missing screening opportunities for A and kidney complication and cardiovascular risk factor identification, and a risk-taking behaviors around alcohol, smoking, drugs abuse, which typically increase. And a psychological change that is also a problem. The diabetes-related family conflicts, the eating disorders, the depression, anxiety, which is very common at this age, the fear for a hypoglycemia or chronic hyperglycemia and ketoacidosis, that the school staff didn't know what to do in emergencies, the issues around sexual and reproductive health become paramount, the driving a motor vehicle, and loss of the follow-up is a common problem at the time of transition and transfer. We have many specific elements of type 1 diabetes and its treatment have been linked to the development of disordered eating behaviors, initial loss of weight at the onset of the disease following by weight gain on initial insulin replacement, occasional weight gain associated with intensive insulin therapy, focus on diet as part of the diabetes treatment, and the need to eat often without hunger due either to peaking insulin action or hypoglycemia. And other factors associated with disorders of eating behaviors include to be female, obese, suboptimal glycemic levels, the presence of depressive symptoms, and executive dysfunction. And disorders, eating and eating disorder, particularly with insulin restriction or omission, can lead to the deterioration in glycemic levels and subsequent complication even in premature mortality. So, besides it, adult diabetes clinics are less likely to have multidisciplinary holistic model of care and are less friendly to young adults. We have a very maternal care for the patients in the pediatric attendance, and when they go to the adult attendance, they lose this maternal point of view. And the adult visits tend to be shorter in duration, excuse me, and tend to focus more on medical treatment. Medical providers tend to focus the visit almost exclusively in the young adult rather than the family, and often assume that the person with diabetes possesses the skill and capacity to perform diabetes care independently. The risk factor for gaps in care include a high number of stressful life circumstances, no college degree, and fewer than 3 pediatric diabetes visits in the year before transition. We need to educate the patients through a program that covers general aspects of the treatment of type 1 diabetes and a specific one for adolescents at least a year before. We have learned that we need to start 3 years before the transition, and in the last year, we discussed with the patient what is the importance of each item for them, and not to consider only the importance and the medical equipment things that are important. Because most of the patients, half of the patients, go to a consultation with an adult not responsible for the treatment, and 30 to 60% stop attending scheduled consultation or only attend the emergency room due to acute complications for the last 2 years. They say there has a dissatisfaction, impaired glycemic control, increase in acute complication, and less early detection of chronic complications. The uptake of diabetes technology is rapidly increasing in young people. Diabetes offer improved glycemic control and better psychosocial outcomes, and the patient knows that, but the government cannot offer them the technical advances for the uh, glucose vigilance or insulin pumps. So there is inequity in access to technology, see, which is one of the key drivers of disparity and may become an ever more pronounced driver of inequities as the diabetes technology is evolving. Diabetes technology use is lowest and hemoglobin 1AC is highest in those from the low socioeconomic status group, which is our population, and higher age, male gender, and migration background are associated with lower use of diabetes technology in adults, even in Germany. From the age of 18, they stop going regularly to consultation because they no longer study and they have no permission to miss days of work, or they study but they cannot miss their classes in the morning, or they are treated at the first level of care, or they do not receive free medication or monitoring items. Uh, when we look for what happened with transition in most countries, we found that in Barcelona, there is no change in the levels of hemoglobin A1C. There is less severe hypoglycemia and less frequent, but knowledge of diabetes increased without change in adherence to self-control. In the Duke University, they found depression in 14%, anxiety 4%, hypertension 7%, hyperlipidemia in 14%, obesity in 9%, and the transition to older age was not associated with better levels of hemoglobin A1C, but was associated with fewer hospitalization and emergencies room visits. In Spain, as general recommendation, they suggest to have a coordination, group education that use the new technologies and psychological approaches. And the transition is far from optimal, and there is still little efficacy and self-control in the loss of follow-up. In the Delphi study in India, they conclude that there is necessity for consensus of care needs, develop relevant intervention strategies, and understand reason for disagreement and expectation of the patients. At last, only 41% of the patient get the goals over hemoglobin A1C, knowledge, self-care readiness, continuous monitoring, and insulin pump use did not differ between those with less than 7 and more than 7% of hemoglobin A1C, while distress and time in range and adherence were better in those with less than 7%. People without continuous care have higher blood sugar levels and are more likely to be hospitalized. This is a meta-analysis of 29 studies that say that adolescent experience of transition to self-management are interconnected with support provided by others, the family, the teachers, the friends. Many adolescents decide to lead their life similar to peers without diabetes during the transition. The reality of daily living is interfered with the ever-present requirements of diabetes. Their frustration with living for a normality is one of the most difficult barriers to self-transition. And the fear of diabetes-related stereotypes are not fitting in with peers, combined with the ongoing burden of diabetes management, can lead to a sense of depression and create barriers for adolescents seeking the life of a balanced life. We must consider that interdependence and collective lived experience is essential to developing effective and personalized family, peers, and social interventions, and the negotiation of role with the network of support that impact adolescent transition and adolescents, and self-negotiation has been negligent. In Mexico, we developed a study 14 years ago with 209 Taiwan diabetes patients who was attended in our clinics and then left the center because of age. We could not obtain information or confirm medical follow-up in 71% of them because or they moved to other place or they are not living in the same house or has not the same telephone. 14 years ago, there is not cellular or iPhones. We know that 8 were dead, 7 from diabetes-related complications. Most patients were seen by primary care physician or by no physician at all, and only 29% of the patients could be reached by phone, telegram, or during their routine clinical appointments. Reviewing their all clinical records as adolescents, two-thirds had poorly controlled diabetes and 16% had proliferative retinopathy. The scarce economic and social resources compel patients not to leaving their work for a medical appointment. Others, as young adults, may lose the family health coverage offered by the social security system. And there may be erroneous attitude toward a disabled child with diabetes, more common in the poor income classes, that leave this patient with no other alternative but to deny their illness. Patients' attitudes such as reluctance to see another physician, take on more responsibility, be overwhelmed by other problems, and they believe that they will be safe just by following the usual indication are some of the coping strategies used by the patient. Unfortunately, patients usually return too late to be followed and treated by their diabetes when the majority of them have already developed serious complications of the disease. Because of poverty and scarce medical and family resources, intensive insulin treatment programs are a real option for less than 5% of our diabetic population. And they have emotional dysfunction. We found in 93 consecutive type patients aged 14 to 30 years, higher scores of emotional dysfunction related to diabetes and diminished knowledge in diabetes-related area. A multivariable logistical regression shows that there is a high prevalence area in diabetes in the PAID score, was mainly associated with a poor glycemic control, and apprehension about the future and the possibility of serious complication had the highest mean PAID score in all age. So in this first study, we found that there is no blood glucose monitoring in almost half of the patient of more than 24 years old. There is peripheral neuropathy in 23, clinical proteinuria in 41%, and high PAID score in 24. And it was no statistical significance. The proliferative retinopathy, end-stage renal disease, autonomic neuropathy, and high diabetes non score is always present. We didn't find any other items. But look, when we look for the patient who was in transition in 1982, and we try to locate it 20 years after, we found, as I say, excuse me, that 87% is management by general practitioners, 66% poor control, 16 retinopathy, 41 proteinuria, 17 neuropathy, Less than 5% has intensive treatment, and 71% has emotional dysfunction. And when we change and have a structured transition, uh, I need, here there is another column. But, well, when we analyze what happened in 22 with the patient that was in transition in 20 years ago, we found no deaths, that 96% is receiving attendance by a endocrine specialist. 16% only have poor control. Only 3% has retinopathy, 1% proteinuria. Uh, Here is, see, 3A was controlled. The retinopathy decreased from 16 to 6, 41% to 12%, 70 to 2%, less than 5 to 58%, and 71% with emotional dysfunction to 80%. So to structure a good program of transition it's much better than just inform the patient about the things. So the take-home mission is the transition period is often difficult to implement in all patients due to their social, family, cultural, economic, school work characteristics, and loss of interest in going to a consultation. There must be a comprehensive health system for all patients, which we don't have in Mexico for all the people. A general program for the transition stage should be established in progress stage, supervised by parents and doctors. And this general program should be individualized to have a greater chance of successful in each patient. A structured process produces much better results than not structured. But structured means that we need to know the patient's necessity and not only the medical proposal for the transition period. And I thank you very much for the attention.
Thank you, Professor Calzada Leon. You very beautifully brought out the challenges in transitioning patients with type 1 diabetes to adult care, especially from an underprivileged population, and many amongst us here in India identify with those challenges. But you have also shown us the way forward. You have presented us evidence that with following a structured transition program, not only these patients get retained in care, their outcome also improves. That's very encouraging. Thank you. Kindly take your seat and we'll go on to the next talk. Thank you.
Professor M.Y. Jalaluddin. He is Deputy Dean and Professor of Pediatrics and practicing senior consultant pediatrician at Faculty of Medicine, University of Malaya Medical Center. And he is going to speak on the transition of adolescents with the bone disorders, the less known area, less discussed area as compared to diabetes. Over to Dr. Jalaluddin.
Thank you very much. Salam and good afternoon, everyone. Thank you for the kind introduction. I'd just like to thank the scientific committee and the organizing committee for giving me this chance to share with you some of the data, some of the experience that we have in managing this group of patients. So when we talk about transition care, we need to understand that it has to be done in stages. So it's not a transfer, but it's a transition. And we know when we talk about transition, we have to first assess the transition readiness, as mentioned earlier. So I'm just going to go touch base only, right? There will need to we also need to have the preparation for transition as well as a follow-up after the transition. And this basically determined by the family and psychosocial support together with the effective communication that we have. Now, the transition models may have restricted applicability to rare genetic diseases for several reasons, because there is a limitations in the access to a variety of specialists. Because most of the bone disorder, you cannot just you cannot just have yourself as speech endocrinology to take care of them. So you need a lot of other people to come in and take care of this group of patients. The consequent lack of knowledge of the disease, which we are still learning, as well as the influence of the long-term caregiver experience on the expectations of the adolescent themselves. So the evidence surrounding transition of care for patients with bone disorders is really lacking. I mean, if you go and look into PubMed or some other, resources, you will really find that there's only a few that talks about transition care. And as you see, for transition care in SLH and transition care in osteogenesis imperfecta, the paper was actually the first paper dated in June 2023. So that tells us that it's very minimal. Yeah. However, this overarching principle remains indispensable. We still need to do something to manage our transition, our patients better. So we need to have a specified timelines, as mentioned earlier, well-defined goals for each transition stage, and clear and distinct roles and responsibilities for all the people involved in the transition care. Okay, so the theme when we talk about transition is that there need to be patient education, whereby this need to gear towards increasing awareness, independence, as well as self-advocacy. And there's a provision of the need for continuous psychosocial support and other considerations that we need to look at when we talk about bone disorder is that what is the final adult height? What is the fertility? What is the fetal risk or heritability? Because this is very important when we talk to parents, yeah, and access to appropriately identified specialists. And transition care for bone disorders, we can look into two different groups, whether this is coming from the primary metabolic bone disorders like the hypophosphatasia, X-linked hypophosphatemia, or even osteogenesis imperfecta. And we don't forget about those from the secondary metabolic bone disorders like sequelae of the hypogonadism, eating disorders, as well as cancer treatment. So for the purpose of discussion this afternoon, I'll just zoom into the XLH where we do have some information, some guidelines that we can talk about and can discuss. So if we look at the SLH, we know that this is a very rare inherited skeletal disorder, a chronic and progressive skeletal disorder that's characterized by renal phosphate wasting due to the excess of FGF23 production. And this is the most common form of heritable hypophosphatemic rickets, and it is inherited through X-linked dominance pattern. Yeah. And it is believed to affect approximately 1 in 20,000 to 1 in 50,000 people. That means it's a very, very rare disease. Anything beyond 1 in 3,000 or 1 in 5,000, depending on which country you come from, this is considered as a rare disease. And a more recent UK study estimated prevalence of 1 in 71,000. So if we look at the inheritance pattern, which is the X-linked dominant, if the father is affected, that means all daughters are affected, but no sons are affected. But if the mother is affected, there's a 50-50% chance that the children will be affected regardless of sex. So it's very important that the parents do understand about this for us to give that kind of transition care, the education about the SLH itself. And this group of patients can present with disease manifestation that span a wide spectrum. A number of times when we diagnose a child to have an XLH disorder, we usually then diagnose either the father or the mother to also have SLH. This father and mother has gone like without knowing that they have issues. Yeah, if you look at the presentation, they can actually present with skull abnormality, craniosynostosis, or even chyli malformations. Not to forget the dental issues. Yeah, the spontaneous dental abscesses, together with microbial invasion of the dental pulp, musculoskeletal, which is mostly seen, with the short stature, bone deformities, as well as radiologic signs of rickets. We cannot forget about the muscular function. Most of these SLH patients do give you the history that their children wouldn't want to walk very far. They do not have that kind of resilience in terms of walking. They keep on complaining about calf pain and something like that. Even when you bring them to shopping complex, they can just go and walk for about 30 minutes, and after that they just get the parents to carry them. So these are some of the things that we need to look into. And don't forget again the bone and joint related problems when it comes to the adulthood. Now, why is it important for us to diagnose them early? Is because it has been shown that if you were to treat them before they are 1 year old, you can definitely improve their height outcome, biochemical outcome, as well as the ricket severity. As you can see on the right panel, whereby the height outcome is much better if you were to diagnose and treat these children below 1 year old. And these are some of the things that we can do to help to prevent all these complications. Identifying them early at a young age. We can also usually diagnose the parents or some or the other family members who may have similar issues but were undiagnosed. And if we were to diagnose early, we can prevent and treat the rickets itself. We can improve the height outcome, as I mentioned, because early initiation of therapy improve height outcome. We can reduce the risk of arthritis as well as joint replacement, especially in the adulthood, and improve the dental health. And the pharmacologic treatment of SLH is not easy, I would say, because the main goal is to heal the rickets, but we need to aim more than that. We need to aim for reduction in skeletal deformity, precluding the surgery. A good number of times, they had multiple operations done by our surgeons before they get to be referred to us. So these are the things that we need to also talk about when we look at SLH patient. The aim include also facilitating the growth, alleviate bone pain, as well as improving dental health with a combination therapy of oral phosphate supplementation as well as active vitamin D. So this treatment has to be started as soon as we diagnose them, and the recommended doses as given there. And most of the time, it is recommended that the phosphate should be given 4 to 6 times per day, almost about every 4 hours, for you to keep the phosphate level nice and stable, that you can avoid the problems of rickets. If these children only takes 2 or 3 times a day, you will see all this bone deformity coming in. This is very important for us to educate them. Phosphate, ingestion of phosphate is not the best thing that you want. It is salty. You have to take it in a large volume. You have to make sure that they take it every 4 hours to 6 hours. If not, you'll have a lot of issues with the bone, the bowing, and all that. And this is just to show you one of my patients who came in and see me when he was about 3. And the mother is only 135 centimeter. The mother has SLH, which has gone unnoticed, have not been seeing anyone. So this boy was very vigilant. The mother kept telling me that I do not want my son to be like me. So he makes sure that his son takes 6 times a day, even wake up at night to just drink the water that has been diluted with the phosphate. And you can see 2-3 years later, it's all nice and straight. But how many of them can do that? Does our adolescent going to do that? So it's very important that we educate them properly and keep on talking about the need for that. And we know this is the limitation of using phosphate. Multiple daily dose is unpleasant taste. And if you were to take in a very concentrated manner, this can lead to a lot of GI issues, dyspepsia, laxative effect of phosphate, and so on. So if they don't understand about all these possible side effects, they would not take the phosphate. Yeah, and we know, as I mentioned earlier, the half-life of the phosphate is quite short. So that's the reason why you have to give it very often to make sure that you can achieve the normal phosphate level all the time. And at the same time, we cannot overdo the treatment because this can lead to hyperparathyroidism, hypercalciuria, as well as hypercalcemia. And the nephrocalcinosis can come in about 50 to 80% of patients. That's the reason why we always ask for an ultrasound KUB to be done every year to make sure that they do not have nephrocalcinosis. And chronic kidney disease can happen in about 8 to 9% in stage 3 or higher. That's the reason why sometimes SLH patients are followed up by the nephrologist, not by the endocrinologist. Okay? And we know, even if we give them good amount of phosphate, you can still have these issues of poor leg length, poor stature, as well as the arm length. But you would not have much issue with the sitting height because the lengthening of the bones, the long bones, is mainly related to calcium and phosphate, but not so much of the spine. There's a reason why the sitting height is usually not so much affected. Okay, but we know we have new kind of treatment. Burosumab is there. Yeah, this is a recombinant human IgG1 monoclonal antibody directed against fibroblast growth factor 23, and it has been approved in the European country for those children above 1 year old and by FDA for more than 6 months. Okay, what does it do? It inhibits fibroblast growth factor 23, directly enhance phosphate resorption from the kidney, and there is some effect on the vitamin D metabolism as well, which it indirectly enhances phosphate reabsorption from the intestine. But how much does it cost? In Malaysia, I can tell you, for a 20 kilogram child, it costs about 800,000. That means it's almost 200,000 USD for one year, because you need to give this infusion every 2 to 3 weeks. Yeah, the child has to come in and you have to give the infusion every 2 to 3 weeks. So it's not just one-off kind of thing. Okay, but even though some kind of treatment is there, it's not a cure. So we have to understand that. And we have to talk about these issues of chronic hypophosphatemia, whether it's in a child, in an adolescent, as well as in adult. I put it here. If you look at the children, the rickets, the delayed and disproportionate growth, together with delayed walking as well as craniosynostosis. In children and adolescents, the short stature issue, the deformity, a good number of them who do not comply very well has to go for multiple times of surgery that's being done, to avoid all this deformity. The osteomalacia can be there, the bone pain, the joint pain and stiffness, muscle pain and weakness, tooth abscesses, as well as excessive dental caries. So these are the things that can happen in these children and adolescents. The gait abnormality, the need to use the walking device, as well as the diminished quality of life, including the psychosocial impact. What about the adults? They can get all the fractures, including insufficiency fractures, as well as the looser zones, early onset osteoarthritis, the extraosseous calcification, the enteropathy, the spinal stenosis, together with hearing loss. And this disability impacts their working experience. Not to forget the psychosocial burden, the negative social experiences, bullying, the unkind remark, as I mentioned to you, the mother told me many times in clinic, I just do not want my son to experience the same that I had. Okay, the low self-esteem, the frustration, the depression that can happen. 16.8% responses from 31 children and 25.6% from 18 adolescents reported psychological burden. Okay, the psychosocial burden, not to forget. The worry about the future, as I showed you just now, this is X-linked dominance. What will happen to my grandchild or granddaughter or something like that, because they keep on thinking that this can be passed on to the next generation. The inability to work, this mother that I mentioned to you, she has to stop working because she just cannot afford to have all this bone pain, taking a lot of MC. Yeah, the well-being of the child, the well-being of the family. Having children with SLH also cause the concern about the risk of passing the SLH gene to the next generation. Okay, so I had a pleasure of being in this group, the Asia Pacific Consensus Recommendation for the X-linked hypophosphatemia that's been been published in June 2023 in the Journal of Bone Mineral Research, headed by Prof. Craig Mann, and the team actually include both pediatric endocrinologists, adult endocrinologists, nephrologists as well. So you can see all the different people in there, try to see how best we can actually manage this group of patients. So first of all, it has to be multidisciplinary. As you can see from the child to adolescent to the adults, you need to involve everyone. SLH is not just pediatric endocrinology issue. It's also the nephrologist issue. It's also the orthopedic surgeon issue. It's also the psychiatrist issue if you need to get them in. So if you look into the center, there is an overarching goals that needs everyone's involvement to make sure that we can actually optimize the transition care of these children. So this just to list down who are the people that need to be in the team for the transition care. So you need a pediatric endocrinologist, you need the orthopedic surgeon, the dentist, the neurosurgeon. If you have these issues with chiari malformation, you need a physiotherapist, otolaryngologist, psychologist, dietitian, as well as the geneticist. So the whole team, this is multidisciplinary. Huge number of people needs to be involved as compared to type 1 diabetes, right? That's why it's very difficult for us to get everybody into one area to get them to be transitioned better. But we have to try. So our group has come up with this very nice cartoon, I would say, the illustration on how and what we need to do when it comes to transition care. So we suggest that this is based on all this literature that we have and the best practice from all the peds endocrinologists, adult endocrinologists in the group. So they need to have this assessment of the transition readiness, as mentioned earlier. And this can happen between the age of 12 to 15 years and or between 4 to 5 years before the transition to adult care. Because we understand in Asia Pacific, some people transfer this group of patients at the age of 18. Some clinic actually start to transfer them when they are 15. That's why the age range, that is difference between 12 to 15. But we need to understand the disease awareness, okay, the patient, the caregiver education, how much do they know about SLH itself, and then introducing the concept of transition during this period and encourage the patient's self-care, independence, and self-advocacy. If we look at the second part of it, which is the preparation for transition, this should happen between the age of 14 to 19 years, which is about 1 to 2 years before the transition to adult care. Here we need to discuss about the optimal time for transition. The transfer letter needs to be looked into already, the checklist, the identification of the adult HCP that has to come in, the questionnaire, the transition readiness questionnaire, encouraging patient self-care together with the getting the XLH advocacy group. Because it's very important. As I said, the number is small. In Malaysia at present, we only have about 35 to 40 patients throughout the country. So these patients in one hospital, there are probably just 3 to 5 of them. They may not even meet each other. So we need to do something to look into how much do they know about SLH. And when it comes to the transition and follow-up, this can be between 15 to 21 years old. there need to be a follow-up after they have gone to the adult group at least 6 months later to understand how it is, to understand whether they have met the HCP there, which a little bit more difficult because the adult endocrinologists are not familiar with this kind of problem, this kind of disorder. So there need to be continued collaboration between the pediatric and adult HCP, even 6 to 12 months after the transition has happened. Now, this guideline also talk about the roles and responsibility, because we need to make sure that the patient has their role and responsibility, the nurse practitioner, the pediatric HCP, as well as the adult. Because if we don't specify each person's role and responsibility, people will just leave them alone, right? So it's important that the patient and the parents and the caregivers also have to have some roles. They need to understand about disease. We need to provide them with the education, the knowledge, so that they don't just drop off from the clinic follow-up once they get to the adult clinic. So the role of the nurse practitioner, because I think most of us, we all are very, very busy with our work day to day. We cannot afford to go and call the patient whether they have gone or not to the next clinic. So you need a person, a point of care person, which is usually the nurse educator or the nurse practitioner, who will take care of them. We also need to make sure the pediatric HCP is on board. We ourselves, the pediatric endocrinologists or even the nephrologists, are on board in looking at all this support, as well as the adult HCP needs to be comfortable to take care of these patients. Most of the time, even in our center, we find it very difficult to find an adult endocrinologist who wants to adopt this adolescent, this young adult, because they are not used to this kind of treatment of patients. The consensus also come up with the questionnaire that they need to look into, the transition readiness assessment questionnaire. We want to look into what kind of questionnaire that is available, whether it is available in your native language, and we also talk about where to have this transition clinic care. And I think we can adopt what is happening in with type 1 patients, where we get the adult endocrinologist to come to our clinic first to get that introduction. So at least about 6 monthly or once a year in the initial phase, so that they kind of know that these patients are around. They kind of try to learn what happens with SLH, because even the adult SLH patients do not go and meet the adult endocrinologists. And we also come up with this checklist. You can go to the paper and look into the checklist that is there. For each patient that needs to be transitioned, these are the things that the pediatric endocrinologist should prepare to pass to the adult endocrinologist, so that the adult endocrinologist have all the data, have all the information that they need about the patient. Okay? And all these are happening because of this. We need to put the patient as the center of care. The patient centricity, putting the patient first in an open and sustained engagement. This is very important. If we are thinking about what we do, how busy we are, it's very difficult. We cannot get this transition care done properly. Patient empowerment is very important. So the reason that we need, because this is a group of patients who are, the very rare disorder. You definitely need to get them to be in a group. They can talk to each other, understand each other, and have this kind of patient focus. The advocacy group that can come from them. All in all, the most important thing is the patient adherence. If they don't understand about the disease, if we don't educate them about the disease, the patient adherence will be poor. Then they do not know what's the priority, the needs. Because of that, they don't see what path they need to follow. If we can put into them that if you were to take care of yourself, get all these medications done properly, you should be able to avoid the possible complications that I mentioned earlier. And because of that, our Malaysian Pediatric Endocrine and Diabetes Group, actually we bring the patients for the patient networking event. This happens in March 2023 last year. We get the patients to come, we talk to them about what needs to be done, what do they understand about SLH. So a lot of sharing session, getting other rare disease patients to also talk about what happened to them, what happened to them in terms of getting the government funding about the treatment. As I showed you, is very, very expensive. So we have the advocacy sharing. Yeah, a mother from Laron, a mother who has a Laron syndrome, 2 Laron syndrome kids who managed to get some funding for the Increlex to treat the Laron syndrome. So we get her to come and talk. The president of the Prader-Willi Society in Malaysia also come and talk to tell them that there's a need for this advocacy so that they can actually work together in a group. So we had a second SLH program, bringing in another group of patients in Malaysia and to show this solidarity. So if we were to do this for them, at least they know that they have some friends out there. They have a group of other people who are also having the same issues. And hopefully, with them talking about themselves, bringing their problems up to the politicians, that can change the policy of the government. So I hope that I've given you some idea on how we can actually manage the very rare bone disorder children during the transition care. This is basically the key message: patient centricity, to get the patient adherence, right? So that they actually own their disease and help themselves to avoid all the complications. Thank you very much.
Thank you, Professor Jalaluddin. Please join here from the dais, and we have the questions answer session after the next talk. And maybe should I invite the next talk is by I'll invite Dr. Ki Takasawa. He is from the Tokyo Medical and Dental University, and on his name these numerous awards, a list of awards are there, and he is going to speak here on the transition of adolescent with adrenal disorders. So after diabetes, then bone disorders, and now on the adrenal disorders. Over to you, sir.
Thank you very much for your kind introduction. Good afternoon, everyone. My name is Kei Takusawa, and I am a pediatric endocrinologist at Institute of Science, Tokyo in Japan. Institute of Science, Tokyo was established on 1st October 2024, following the merger between Tokyo Medical and Dental University and Tokyo Institute of Technology. It is a great honor to be here today at the APES Aspire Joint Meeting 2024, and I thank you all for your attention in the last session. This is my first trip to India, and it has been a wonderful experience. Today I will be discussing a topic that is not only close to my professional focus, but also crucial for the health and well-being of many young patients. The title of my presentation is Management of Congenital Adrenal Hyperplasia CH during Adolescence and Transition to Adult Care. I will use CAH as an example to consider the challenge of transition medicine in adrenal disorders. I have no COI. Our discussion will follow a structured path. First, a brief overview of CAH. Then, we will delve into the unresolved issue in its management. And finally, I will share with you some promising future perspectives. Let me begin with an overview of CAH. As you all know, CAH is a group of disease caused by congenital disorder of enzyme involved in steroid hormone synthesis in the adrenal glands. In particular, negative feedback from impaired cortisol synthesis result in excessive secretion of ACTH from the pituitary gland, resulting in adrenal hyperplasia. There are several forms of adrenal hyperplasia, including lipoid hyperplasia, 3-beta HSD deficiency, 21-hydroxylase deficiency, 11-beta hydroxylase deficiency, 70-alpha hydroxylase deficiency, and PORD. And the causative genes for each have been identified. In each form of CAH, various symptoms such as glucocorticoid and mineralocorticoid deficiency, hypertension due to an excess of intermediate products, DSD due to excess androgen, adrenal androgens excess, and sex hormone deficiency may occur. CAH is reported to occur in approximately 1 in 20,000 live births with 21-hydroxylase deficiency, accounting for 19% of cases. In this presentation, I will focus on 21-hydroxylase deficiency, 21-OHD, which is the most popular CAH. Biallelic pathogenic variant in the CYP21A2 gene result in a 21-hydroxylase defect, which cause a downstream cortisol and aldosterone synthesis defect, resulting in adrenal insufficiency and salt loss, as well as virilization due to adrenal androgen excess. In addition, hyperpigmentation results from ACTH excess caused by negative feedback from cortisol deficiency. The excess of 70-OHP, an intermediate product, is used as an indicator in newborn mass screening for diagnosis. The 70-OHP is a very powerful test for diagnosis and treatment monitoring, but there are still some issues to be addressed. In Japan, the prevalence of 21-OHD is approximately 1 in 20,000 live births, equating to around 40 new cases per year. Since 1989, newborn screening has been started, significantly reducing the morbidity and mortality associated with CAH during infancy and childhood. Recent studies indicated an extremely low mortality, but adrenal crisis still occurs in infants and younger children. Risk factors of adrenal crisis are reported as increased number of infection and younger age than 3 years old. Functional analysis of the CYP21A2 gene has revealed a certain correlation between its genotype and phenotypes. Variants with zero enzyme activity, such as R357W, typically lead to the salt wasting type, while variants with some residual enzyme activity, like P31L and V282L, are more likely to cause the non-classical form. This slide shows the external genital findings and genotype of our own 46XX21-OHD cases. It appears that virilization and salt wasting are generally correlated with the genotypes. Continuing appropriate treatment for 21-OHD according to growth is challenging. It is not simply about supplementing the deficiency, but rather involves suppressing androgen excess and making adjustments to prevent it from overdose. Monitoring the effectiveness of glucocorticoid therapy, which is the cornerstone of CAH management, is essential to avoid both under and over treatment. We must aim to prevent adrenal crisis, growth deficiency, and virilization without inducing side effects like iatrogenic Cushing syndrome. Despite of advance of diagnosis and treatment for CAH, several unresolved issues still persist in the management of CAH. These challenges span more accurate newborn screening and genetic diagnosis and improvement of treatment outcome with monitoring, adherence, and critically the transition from pediatric to adult care. Now let's explore some of the unresolved issues in the management of CAH, starting with newborn screening. While newborn screening has been a game changer in early diagnosis, there are still significant limitations. The positive predictive value, PPV, of these tests varies widely between countries, but generally low. Low PPV is indicated high false positive, resulting in low cost effectiveness and obstacle to early diagnosis. 70-OHP test in newborn mass screening is affected by gestational age and birth weight. This is thought to be due to cross-reactivity with similar substance from the fetal adrenal glands. In Tokyo, the cutoff was adjusted by gestational age and birth weight, and the PPV was increased to around 40% for full-term birth and 25.8% on average. However, the overall PPV is still not high enough due to the low accuracy of the result for pregnancies of less than 37 weeks. Genetic diagnosis also presents considerable challenges. Also, definitive genetic diagnosis is clinically significant for exclusion of other CAH, genetic counseling, and gene therapy in the future. The CYP21A gene has a highly homologous pseudo gene, CYP21A1P, which complicates standard PCR and NGS techniques. Advanced methods such as nested PCR combined with MLPA have been developed to overcome these obstacles, but they are not yet widely available or standardized. When it comes to treatment outcome, there is concerning data. We showed these studies from Sweden and the UK show that CAH patients have a significantly reduced median age of death compared to the general population caused by cardiovascular disease. This underscores the need for better long-term management strategy to mitigate metabolic risk and improve life expectancy. Another critical aspect of CAH management is monitoring and adherence. Despite consensus guidelines recommending comprehensive monitoring, including growth velocity, pivotal stage, and bone advancement, there is still no gold standard for treatment monitoring. This gap in our clinical practice contributes to suboptimal management and highlights the need for more precise and standardized tools. Adherence to treatment is another major concern. Recent studies have shown a significant gap between self-reported adherence and physician assessment, and non-adherence rate increased with age. This discrepancy is particularly troubling during the transition from pediatric to adult care, and poor adherence can lead to serious complications. This brings us to one of the most challenging phases in the management of CAH, the transition from pediatric to adult care. In the transition period, change of treatment goal is crucial, yet many patients struggle with this shift. The clinical practice guideline recommends gradual transition in joint clinic for several years. I think that transition should be started with diagnosis, and appropriate transition would be required for optimal lifelong management. In the UK, nearly 90% of adult CH patients are not under the care of an endocrine specialist, and almost half of patients dropped out after transfer to adult healthcare. This lack of continuity in care can lead to poor health outcomes, underscoring the need for structured and supported transition programs. In Japan, a recent survey of adult classic 21-HD patients reveals that 15% of them are followed by pediatric endocrinologists. And age at transfer was higher in women, and some patients returned to pediatric after transfer. Major reason for continuing in pediatrics in patient request rather than lack of counterparts, which indicates more need for patient education in pediatrics. Most of transfer patients to internal medicine in the same hospitals, which indicate increase of counterparts can promote effective transfer. Among other 21 HD cases followed in pediatrics, 27.5% had obesity, and 1 out of 4 of them was complicated by hypertension or dyslipidemia. Furthermore, 40% of obese cases were under the age of 30, suggesting that treatment in childhood may have an effect on obesity in young adult patients. And the frequency of osteoporosis and infertility cases were not different from that reported overseas. But there were many unknown cases in which the presence or absence of the respective conditions was not confirmed by pediatric endocrinologists. In addition, 12.5% of male patients were found to have TAT, and 30% of female patients had gynecological complications, which reminded us of the need for collaboration among other experts. The successful transition required disease education in accordance with the child growth and development, as well as promotion of autonomy and independence. For healthcare providers, it is essential to raise awareness of transitional care on the pediatric side, train counterparts in adult medicine, and provide multidisciplinary team-based support. Despite these challenges, there have been significant advances in CH management that offer hope for the future. One of the most promising developments is the improvement in newborn screening through the use of liquid chromatography tandem mass spectrometry, LC-mass. Our new algorithm using LC-mass has dramatically increased the PPV from 41% to 92% without increasing cost. In the area of genetic diagnosis, the introduction of long-read sequence technologies, such as nanopore sequencing, has significantly enhanced the accuracy of identifying CYP21A2 mutations. This method offers 100% accuracy compared to the 76% accuracy of traditional MLPA, enabling early and precise genetic diagnosis, which is crucial for appropriate management. Indeed, we identified several novel variants, chimera, and double mutations in Japanese cohort. In terms of therapy, new strategies are being explored to improve patient outcomes. Sustained release hydrocortisone formation and CRF1 receptor antagonists are being investigated for their potential to provide more physiological cortisol levels and reduce androgen excess, resulting in reduction of total hydrocortisone dosage. The management with these new drugs may improve the quality of life for patients with CAH. Looking further into the future, novel therapeutic approaches such as adrenocortical cell replacement and gene therapy hold promise for potentially curing CAH rather than just managing its symptoms. These therapies are still in the experimental stage, but they represent a significant step forward in the treatment of this complex disorder. One of our primary goals is managing CAH is to prevent long-term complications, including cardiovascular disease, metabolic syndrome, bone health issues, and gonadal dysfunction. The Japanese cohort study revealed lower frequency of osteoporosis and TAD. Infertility due to poor disease control was reported as 11%, but childbirth was only 3.2%. The lack of adequate checks by pediatric endocrinologists may have contributed to these findings. However, providing support for fertility, pregnancy, and childbirth in adult CAH patients is an urgent issue that demands immediate attention. More cautious problems may be reproductive challenge and psychological problems. Decreased fertility with CAH is most commonly caused by excess androgen production. Also, women with CAH present with higher infertility rate, pregnancy rate are similar in comparison to the general population. Gynecological and psychological problems may be hidden behind the infertility of CAH women, requiring specialized support from multiple disciplines. This slide summarizes the framework for preventing long-term complications of CAH. I propose multifaceted and comprehensive evaluation of treatment monitoring and gradual and age and develop appropriate approach by multidisciplinary team starting just after diagnosis to foster patient autonomy and enlighten medical staff. We must recognize that the transition medicine begins the moment of diagnosis. Recently, it was reported that transition readiness significantly correlates adherence and QOL. Gradual education and multidisciplinary support can foster autonomy and adherence, leading improvement of QOL and long-term outcomes throughout promotion of transition readiness. As you all know, checklist is useful for visualizing transition readiness. In Japan, we are beginning to operate a checklist for transition at the initiative of JESPEL. Indeed, I realized that my adult patient with 21 OHD understood less about their illness than I had anticipated. Besides, we promote a new project for CAH to organize a nationwide registry and establish new genetic analysis and monitoring indicator. We pediatric endocrinologists play the leading role of lifelong healthcare supporting for CAH patients and their families. We are required to be aware of the need to not only manage treatment in childhood, but also to promote preparation to establish independent and autonomous self-management in the future. This slide shows take-home message from my presentation. Unreasonable ratio of CAH, more accurate screening and genetic diagnosis, and improvement of monitoring, adherence, and transition system. Advance in diagnosis, monitoring, and treatment will shed a light to lifelong care of CAH patients. Transition is crucial and need gradual education for autonomy from childhood and continuous support with multidisciplinary team. This is all my presentation. Thank you for your time and attention. Thank you all for giving me this opportunity today. Thank you.
Thank you, Dr. Key. Can you join on the dais for the question answer session? And to start, meanwhile, people are getting ready. The question for you, Dr. Key, is that what is your experience about the TART and how you are managing the TART patient and what you can do for the prevention?
Question for you. The question
TART.
for TART. For TART.
Management of TART.
Management. What's your experience?
Management of TART in the CH patients.
Sorry. The management.
Testicular adrenal rest tumor.
Yeah. How do you manage that?
So management of TART and how you are plan to prevent it, or if it is developed, then what is the treatment, or what you do in your clinical practice?
Screening of by echo, intensive and treatment management, dose, increased dose of hydrocortisone.
Yeah,
Dr.
yes.
Kocher.
So this is for Dr. Jalaluddin. They are very nice case of XLH. So I just want to know, because we also have few patient XLH, because we find that we when we go for transition, the patient do not do well in our time, do not do well even after transition. So how do you solve that problem?
Thank you. Yes, the issue is for us. Okay, I would say I work in both the government side and the private side. The one that on the government side, I would say, when you don't see them every time they come, they are seen by your team. You don't get that kind of personal, the treatment, the management. And this group of patients usually have a little bit more problem with the compliance. But the patient who come to see you every time, you kind of like build up that relationship. Then most of the time, these patients are very compliant. They really follow that 4-hourly kind of treatment and avoiding all those complications. So I guess the treatment adherence also involve how we actually talk to them on how we educate them on taking ththose medications.
Yeah. So the question to you, Dr. Jalaluddin, is that there's another a comment rather than it is as compared to diabetes, where the adult endocrinologist started seeing patient with complications actually, and the bone disorders, the many bone disorders, they're actually improving with in adolescent and adult age because there is remodeling is less as compared to the growth period when they require more nutrition and all. So like for example, fibrous dysplasia, there is in quiescent stage. Even OI patient, those are more number of fractures, but the adult enter to the adult or adolescent, the fracture number are reducing. So it is a good thing actually. But very important point is that you diagnose lot of family members with this rare disorder which were actually missed over a period of time. Yeah.
I think just comment on that, because most of the time the adults, when they have this kind of bone disorder, they kind of like ignore it. Although they have the pain, they have the arthritis issues, they kind of like ignore, or even the teeth issues, they kind of ignore because to them it's part of their life. But if it happens to their kids, that's not what they want. Yeah. So if we're able to tell them from the beginning that this can be avoided, I I think that would be better in terms of us transitioning them to the adult care.
And the male genders are the another issue, because you search for the male gender and you should always ask the female siblings might be suffering, but this many times does not bring into the notice of the clinician. So we should ask for that also. This.
So if I put together the three presentations, what emerges is, one, transition of care need is here to stay, as most of the endocrine disorders are chronic, and our children, as they grow older, they need to transit. But what comes out is, one, we need to empower our patients in self-care. We need to follow a multidisciplinary approach, and there has to be a transition readiness which we have to assess, and there has to be a gradual relinquishing with hand-holding. Together with these approaches, we might be able to improve the outcome in our patients. But what I would like to stress is, since we are the primary caregivers, by we I mean the pediatricians, the responsibility lies upon us, the pediatric endocrinologists, to engage with our adult colleagues, motivate them, get them interested, and establish the processes for the transition. So we need to begin, and we need to involve them. And I would just like to inform everybody here, you might not be aware that the Directorate General of Health Services, Ministry of Health and Family Welfare, has actually brought out a transition of care policy to be followed at a nationwide level, and that has been circulated to the states. And that should begin as a good sensitizing document.
Yeah, maybe
Thank
it
you.
is a high time to have a transition clinic rather than just referring the patient. Half of patients are actually not reaching to adult center, so that may be a transition clinic where 1 or 2 hour common, so that can be managed in better way and for better compliance. Yeah, thank you. So we already received the message from the organizers that we should close the session. So thank you very much for this opportunity and all the three speakers for the wonderful job. Give them a big hand to all the.
Professor Riaz and Professor Vanna Jain to kindly felicitate our speakers and chairpersons. Before we move on to the valedictory session, three important announcements. Kindly collect your lunch boxes before leaving the hall after the valedictory session. The certificates of participation will be mailed to you within a week, and after you fill up your feedback form, that will be the Google form. And the photographs of the conference will be available on the conference website within 3 working days. So please stay back for the valedictory session, and I hand over to Dr. Ashima. No, we have the valedictory session during that.
As we draw